Hello, in this video we are going to talk about the nerves of the upper limb and we are going to discuss the roughy points related to chapter 19 of 12th edition. We are going to discuss points related to the cranial nerve, not the cranial nerves, the upper limb nerves, and we are going to talk about the important MCQs that are repeatedly asked in the FCPS. We are going to talk about the brachial plexus that is formed by the union of the anterior rami of the C5, C6, C7, C8 spinal nerve. Along with this, there is also first thoracic spinal nerve. The plexus is divided into roots, then there are trunks, divisions, and cords. The roots basically enter the base of the neck between two muscles, that is cutaneous anterior and cutaneous medius muscle. The trunk and the divisions cross the posterior triangle of the neck, and the cords become arranged around the axillary artery in the axilla. And here the brachial plexus and the axillary artery and vein are enclosed in the axillary sheath. So it could be an MCQ asked in the FCPS part 1 that the cords become that which part of the brachial plexus is present in the axillary sheath, and the answer is going to be the cords, not the trunks, not the branches, not the any other thing, or not the whole plexus, not the roots, but the cords, that is the posterior cord, the medial and the lateral cords that is going to be present in the axillary sheath. If we talk about the cords of the brachial plexus, there are three cords: lateral cord, medial cord, and the posterior cord. In this video we are going to discuss the main branches of the lateral and the medial cord, and in the next video we are going to talk about the posterior cord. The lateral cord has three branches: the lateral pectoral nerve, the lateral root of the median nerve, and the musculocutaneous nerve. And the mnemonic to remember these three nerves is 2LM or 2LM. That is present. This mnemonic is also discussed in the roughy point as well, so it's easier for you to remember 2LM. So lateral pectoral nerve, lateral root of median nerve, and musculocutaneous nerve. And the important nerve which we are going to talk about is the musculocutaneous nerve, that is the branch of the lateral cord. About musculocutaneous nerve, you need to remember that it supplies three muscles: coracobrachialis muscle, both heads of bicep brachii, and brachialis muscle. It pierces the deep fascia and it supplies the skin along the lateral border of the forearm, where it becomes the lateral cutaneous nerve of the forearm. So if an MCQ is there that there is a brachial plexus block and patients still feel pain on the lateral aspect of forearm, which nerve is spared? So that means that the lateral cutaneous nerve of the forearm is not damaged, and that is the branch of the musculocutaneous nerve. Then there is an MCQ related to the musculocutaneous nerve. The lateral cord of brachial plexus supply which muscle? So bicep brachii muscle, that is supplied with musculocutaneous nerve, and the musculocutaneous nerve is a branch of the lateral cord. So the answer is going to be bicep brachii muscle. Both heads of bicep brachii muscle are supplied by the lateral cord. Then there could be an MCQ: a patient present in ER following the road traffic accident with damage to lateral cord or brachial plexus. Which of the following muscle will be affected? Right. So which of the following muscle is going to be affected if there is a damage to the lateral cord of the brachial plexus? So the another branch of the lateral cord is the lateral pectoral nerve, and that supply the pectoralis major muscle. So lateral pectoral nerve supply the pectoralis major muscle. That could be remembered by the word pectoral. So the damage is at the lateral cord. So these are the MCQs that are related to the lateral cord of the brachial plexus. Then we are going to talk about the medial cord. Medial cord, the mnemonic to remember the branches is 4MU, right? And 4MU stands for, there are 4 M's, that is medial pectoral nerve. Lateral pectoral nerve is a branch of the lateral cord, and medial pectoral nerve is a branch of medial cord. Whereas the medial branch of the median nerve is also the forms the median. So basically the lateral root is from the lateral cord and the median root is from the medial cord. The other two nerves is the medial cutaneous nerve of the arm and the medial cutaneous nerve of the forearm. The medial cutaneous nerve of the arm is joined by the intercostal brachial nerve and they form the second intercostal nerve, and U is for the ulnar nerve. Now we are going to talk about the median nerve and the ulnar nerve. Median nerve is also known as a labral nerve, and it results that injury to the median nerve results in the ape hand. It descends on the lateral side of the axillary and the brachial artery. So it's going to be on the lateral side. When we are going to talk about the ulnar nerve, that nerve is going to be on the medial side along with the ulnar artery. So the median nerve is going to be on the lateral side of the axillary and the brachial arteries, and halfway down the arm it it crosses the brachial artery to reach its medial sides, and then it's going to come on the medial side of the brachial artery. The nerve then descends to the forearm between the two heads of the pronator teres muscle. Supply by the median nerve can be remembered by the mnemonic LOAF. L is for lumbrical muscles. Only the first and the second lumbricals are formed by the supplied by the median nerve. Then O is for opponent pollicis, A is for abductor, and F is for flexor pollicis brevis. You have to remember that it is an abductor. The abductor is supplied by the median nerve. So if an abductor is damaged, the injury is going to be result in the adduction of the hand. Injury to the median nerve, it's going to result in loss of opposition of the hand, and it's also going to result in thenar wasting. These branches of the median nerve supply the palmar aspect of the lateral 3.5 finger and the distal half of the dorsal aspect of each finger as well. So if you can see in the image, the blue color shows the median nerve. So it's the palmar aspect, the lateral 3.5, and on the dorsal aspect, the distal half of the lateral fingers as well. Raphi point 449, and in this video we are going to talk about the median nerve. So now just quickly read out the MCQs that can be asked related to the median nerve. Thumb is adducted and laterally rotated. So which nerve is damaged? As we have already talked about it, that median nerve supply the abductor. So the muscle is going to result in adduction if there is damage to the median nerve. Patient can't oppose his thumb and little finger. The nerve damages the median nerve. Patient can't oppose the thumb. While taking blood sample at cubital fossa, which nerve is most likely to be injured? And the answer is going to be median nerve. Patient lost sensory sensation on the lateral palmar aspect of the hand and unable to flex the index finger, and that is going to result in the lesion in the median nerve. A patient comes with history of tingling sensation of the hand and inability to grip things properly, and there is a wasting of thenar muscle. So whenever there is a key of wasting of thenar muscle, then that result in the median nerve damage. Long scenario where the patient can't hold bottle, makes sensation of the thumb, losses flexion at the distal phalanx of the thumb. The nerve injury is going to be the median nerve. Regarding carpal tunnel syndrome, there is going to be a loss of thenar eminence. Median nerve supply defect will result in the carpal tunnel syndrome, and the carpal tunnel syndrome is going to result due to the compression of the median nerve. So then there is carpal tunnel syndrome is wasting of thenar eminence, loss of sensation over the thumb and the index finger. Nerve involved is the median nerve, where they supply the lateral 3.5 fingers. Patient present with injury, the thumb is laterally rotated and the thumb is adducted. Most likely nerve injuries, median nerve. Median nerve damage above flexor retinaculum, thenar sensation also lost. What else is lost? So that is the opposition of the thumb. Characteristic of the carpal tunnel syndrome, there is going to be sensory loss to lateral 3.5 fingers. Carpal tunnel syndrome occur in which of the following condition? That occur in myxedema, that is an hypothyroidism. So if the patient of a hypothyroid lady has loss of sensation in the index and the middle finger, what other feature is also related? So there is a loss of opposition of the thumb, as it supplies the opponent pollicis muscle, that is a thumb opposition muscle, and then there is a flexor pollicis brevis also, so there is going to be loss of flexion as well. Of the medial cord of the brachial plexus is the ulnar nerve, 4M and U, and ulnar nerve arises from the medial cord of the brachial plexus and it descends along the medial side of the axillary and the brachial artery in the interior compartment of the arm, and then at the middle of the arm it pierces the medial intermuscular septum and it passes behind the medial epicondyle of the humerus. This point is very important because it is repeatedly asked in the MCQs that the fracture of the medial epicondyle of the humerus can result in damage to the ulnar nerve. Then it enters the interior compartment of the forearm and descend behind the flexor carpi ulnaris medial to ulnar artery. At the wrist, it's going to pass anterior to the flexor retinaculum. So this structure, the ulnar artery and the ulnar nerve, they're going to lie superficial or anterior to the flexor retinaculum, and it lie lateral to the pisiform bone. It then descends into the superficial and deep terminal branches. The branches of the ulnar nerve, then the important branches is that in the forearm it is going to give the dorsal cutaneous branches that supply the skin over the medial side of the back of the hand and back of the medial 1.5 finger over the proximal phalanges. As you can see in the image, that it supplies the medial 1.5 finger over the proximal phalanges on the back of the hand, and on the front of the hand it supplies the medial side of the hand. And it is going to give superficial and deep branches. The superficial branches supply the palmaris brevis muscle, and the cutaneous branches are going to supply the skin over the palmar aspect of the medial 1.5 finger. So the palmar aspect is supplied by the branches, superficial branch that is being present in the hand, whereas the when the ulnar nerve give the branches in the forearm, then that is going to supply the back of the hand. So this is also important for you to remember. Then if you see the deep terminal branches, they basically give off the following branches which are important for you to remember. It supply the adductor pollicis muscle. So that means that if the adductor pollicis muscle is damaged, so that means the nerve damages the ulnar nerve, and that is going to result in the abduction of the hand. And then there is going to be damage to the opponent digiti minimi, flexor digiti minimi, all palmar and all dorsal interosseae, third and fourth lumbricals, and adductor pollicis muscles. And articular branches, they give articular branches to the carpal joints. That is also known as a musician nerve or a claw, and its damage result in the claw hand. Why is it known as a musician nerve? Because it controls the coarse movement of the hand. It's called musician nerve because it controls the fine movements of the finger, and its deformity will result in the claw hand. So if there is an MCQ, a loss of sensation on the medial side of the hand and claw of two medial fingers in distal interphalangeal, which nerve is damaged? The answer is going to be ulnar nerve. The important nerve supply of the ulnar nerve, third and fourth lumbricals, along with all the interosseae muscle, adductor pollicis muscle, the short muscle of the little finger is abductor digiti minimi, flexor digiti minimi, and opponent digiti minimi, and supply the skin over the medial side of the back of the hand and medial 1.5 finger over the proximal phalange. So this is important for the ulnar nerve, that these branches are more important than the ones we have previously discussed. Okay, now the few more MCQs related to the ulnar nerve discussed in the Rafi point 449. So damage to medial condyle will most likely cause damage to which of the following muscle, and that is the adductor pollicis muscle, because medial epicondyle is related to the ulnar nerve, and ulnar nerve is responsible for the supply of the adductor pollicis muscle. A boy falls down and fractures his medial epicondyle of the humerus, and that results in damage to the ulnar nerve. Sensation in which area would be affected? That is the distal and the palmar aspect of the medial 1/3 of the hand. Injury to ulnar nerve behind the medial epicondyle causes a loss of sensation in the medial 1/3 of the palmar and dorsal aspect. Sparing the lateral part of the narapinus means conspicuous wasting of other small muscle of the hand, suggests a lesion of ulnar nerve. After an incised wound at front of the wrist, the patient was unable to perform adduction of the thumb and abduction of the little finger. Sensation of the skin of palm were intact. The most likely injured nerve is deep ulnar nerve. So it is mentioned that the deep ulnar nerve is responsible for the deep ulnar nerve is responsible to supply the palmar aspect of the hand, right? So we need to remember this. Structure passing above the flexor retinaculum and the structure passing superior to transverse carpal ligament is the ulnar nerve and the ulnar artery, and the other structure that pass superficial to the flexor retinaculum are the tendon of palmaris longus and the palmar cutaneous branch of median nerve and the ulnar nerve. So it's important that if there is a laceration of the wrist, so which structure is likely to be injured? The laceration of the wrist is going to damage the structure which are superior to transverse carpal ligament, and that is ulnar nerve and ulnar artery. Other MCQs that is related to ulnar nerve is the fracture of the medial condyle of the humerus and the fracture of the hook of the hamate bone is the ulnar nerve. For the person who fell on the outstretched hand, then there is going to damage the ulnar nerve. And if there is an attempt to cut the wrist structure, damage superficial to flexor retinaculum, the answer is going to be ulnar nerve and ulnar artery. So laceration of the wrist or attempt to cut the wrist, the answer is going to be ulnar nerve and ulnar artery. So this was all about the nerves of the upper limbs. We have discussed the musculocutaneous nerve, ulnar nerve, and the ulnar nerve, musculocutaneous nerve, and the median nerve. We are going to talk about the radial nerve and the other important points in the next video. So keep watching our videos. Thank you for listening.